So hello and welcome everyone. We're going to get underway now. So my name is Bill Callery. I'm going to be moderating the webinar, and I'm Manager of Programs and Knowledge Exchange at CDPAC, or the Chronic Disease Prevention Alliance of Canada. And to give you a little bit of background about who we are, we're really a group of many of the largest national health charities and professional organizations in Canada who share a common vision for an integrated system of research, surveillance, policies, and programs for maintaining health and preventing chronic disease in Canada. So if you want to learn more, we've got our website and social media contacts at the bottom. And we encourage you to connect with us to learn about upcoming events and check out materials from our past events. Today's webinar, it's part of a series of webinars being co-hosted by the Chronic Disease Prevention Alliance and Public Health Agency's Centre for Chronic Disease Prevention. It's entitled Mood and Anxiety Disorders in Canada, Prevalence and Public Health Prevention Efforts. So we're extremely pleased to be co-hosting the webinar. And today this webinar is going to highlight results from a recently released study examining the characteristics, health status, health service use, and perceived need for care among Canadians with symptoms compatible with a mood disorder versus without a professional diagnosis. It'll present recently published information from the Public Health Agency of Canada's Canadian Chronic Disease Surveillance System on the national surveillance of mood and anxiety disorders in Canada. And it's going to provide an overview of PHAC's collaborative efforts to promote mental health and prevent mental illness. So we've got three presenters today from the Public Health Agency of Canada. Our first presenter, Louise McRae, is a senior epidemiologist involved in surveillance relating to musculoskeletal conditions, chronic respiratory diseases, and mental illness. Siobhan O'Donnell is an epidemiologist involved in musculoskeletal conditions and mental illness surveillance. And Tracy Reynolds is with the Public Health Agency of Canada's Mental Health Promotion Unit within the Centre for Health Promotion. And she's been promoting the value of good mental health for the last 6 years. And not on screen, but we've also got their colleague Neil Rancourt, who's going to be helping out with moderating the discussions and questions at the end of the webinar. So I will transfer control over to you, Louise, and pass it over to you.
Great. Thanks, Bill. I wanted to take some time to present some highlights from a report that was actually just released yesterday on the use of health services for mood and anxiety disorders in Canada. So just before I delve into the report, just like to situate us in terms of what we mean by public health surveillance and of mental illness in particular. Mental health surveillance is the tracking or forecasting of health events or health determinants related to mental illness through the regular collection of the best available data. It's the integration, analysis, interpretation into surveillance products, and the dissemination to those who need the information. And it's really done to inform public health actions, programs, and policies. Now, in terms of mental illness surveillance at the Public Health Agency, it's conducted as part of the work of the Surveillance and Epidemiology Division, and we lead mental illness surveillance as well as other chronic conditions. Some of our key data sources include the Canadian Chronic Disease Surveillance System, which I'll be discussing today, which is based on physician billing and hospitalization administrative data from provinces and territories. And we also use national surveys from Statistics Canada, including the Canadian Community Health Survey and the Survey on Living with Chronic Diseases in Canada. And so these surveillance activities are conducted in liaison with, we have a Mental Health and Mental Illness Surveillance Advisory Committee. The CCDSS work has been built with the input of the Mental Illness CCDSS Working Group as well as the CCDSS Science Committee. And we also liaise with an initiative spearheaded by the Mental Health Commission, which is the Mental Health and Addiction Information Collaborative, which brings together partners who have an interest in data relating to mental health and addiction. So just a bit of background in how the mental illness surveillance has evolved over the years. It really started around 1999 with the development of some surveillance indicators. Followed by 2002, there was the first report released by Health Canada entitled A Report on Mental Illness in Canada, which was really developed in partnership with the Mood Disorder Society of Canada. Then in 2004, the agency was established, And following that, a second report was released in 2006, The Human Face of Mental Health and Mental Illness in Canada. And then in 2008, the Public Health Network Task Group on the Surveillance of Chronic Disease and Injury endorsed plans to expand the CCDSS using provincial and territorial health administrative data to include mental illness. And then a year later, we were conducting the first national pilot using this platform for the surveillance of mental illness and mood and anxiety disorders. And then following that, in 2011, mental health was identified as a branch priority for the Health Promotion and Chronic Disease Prevention branch. In 2013, the budget for the federal government committed the agency to reallocating $2 million to improve data collection and reporting of mental illness and mental health. Then within the same year, we were developing a survey which was conducted in 2014, which was the survey on living with chronic disease in Canada, focusing on mood and anxiety disorders. In 2014, we began some further expansion of the CCDSS platform through looking at some national pilot data for surveillance of schizophrenia and delusional disorders. And then last year, we had two products which we released, the first being a mood and anxiety disorder in Canada fact sheet, which really highlighted some of the results from the survey on living with chronic diseases in Canada. And we released the first report on mental illness in Canada from the CCDSS as well. And so this is the cover of the report that was released yesterday, available on the website, report from the Canadian Chronic Disease Surveillance System, Mood and Anxiety Disorders in Canada. Just to provide a bit of background in terms of the Canadian Chronic Disease Surveillance System, which I will probably continuously refer to as CCDSS. In 2010, it was expanded to track information on mental illness and mood and anxiety disorders in Canada. The report that I'm speaking about today, Mood and Anxiety in Canada, is the first agency publication to use linked administrative health data, that being hospitalization and physician billing, for the surveillance of mood and anxiety disorders, and to include children and adolescents under the age of 15 years with a focus on mood and anxiety. It's part of a direct response to the commitment of Budget 2013, which I referred to, reallocating $2 million to improve data collection and reporting of mental illness and mental health, as recommended in the Mental Health Strategy for Canada. So the CCDSS really has its origins in national diabetes surveillance, beginning as the National Diabetes Surveillance System, and it's a collaborative network of provincial and territorial chronic disease surveillance systems, collecting information on prevalence, incidence, mortality, and use of healthcare services for selected chronic diseases and disorders. It provides summarized data on Canadian residents covered under provincial and territorial health insurance plans, which covers about 97% of the population, with the exception of those covered under federal health programs, including military personnel, RCMP, and inmates of federal correctional facilities. So on this slide, we have a bit of a visual of how the data is linked together in the CCDSS. So it's basically, there are three data sources. There's an insurance registry, hospitalization data, and physician billing. And those three data sources are linked together using a unique personal identifier. The insurance registry provides some demographic data and all-cause mortality. And then the hospitalization and physician billing is where we're able to identify cases, identify comorbid conditions, as well as use of health services. So just a bit of technical context on the report. It's including data from the 10 provinces and the Northwest Territories. Nunavut was not included as the data weren't available prior to 1999, and the Yukon was excluded because of data quality issues at the time. So the data in the report includes from the years 1996-97 to 2009-10, and unfortunately, surveillance of mood and anxiety disorders separately was not possible. This was determined in the feasibility stage of this work that we weren't able to separate the conditions. There were some inconsistencies in how the data was reported across the provinces and territories. Therefore, a decision was made to group mood and anxiety disorders together, so that the estimates represent individuals who may have had mood disorders only, anxiety disorders only, or both mood and anxiety disorders. So in terms of how we defined a case within the CCDSS, an individual had to have at least one visit to a physician with the first field coded as a mood and anxiety mood or anxiety disorder, or have a discharge from a hospital with the most responsible diagnosis coded as a mood or anxiety disorders, as per the International Classification of Diseases, or ICD-9 or 10, within a one-year period. So in the case of mental illness and mood and anxiety disorders, we use the term prevalence to refer to the estimated annual prevalence of health service use for mood and anxiety disorders rather than a disease prevalence. And this is because the data is limited to people who used health services, who actually were using the health services for a mood and anxiety disorder, and it also does not include those who have only sought privately funded care, and all psychiatric hospitals and hospitals with dedicated mental health beds. So in terms of what's included within those diagnostic codes, for mood disorders, the codes include major depressive disorder, bipolar disorder, dysthymic disorder, depressive disorders not elsewhere classified, which includes perinatal and postpartum depression. And then in terms of anxiety disorders on the next slide, it includes generalized anxiety disorder, social phobia or social anxiety disorder, specific phobias, reaction to severe stress and adjustment disorders, including post-traumatic stress disorder. However, this category was only partially covered because there were some changes from ICD-9 and 10, which made it that we were not able to include it completely. It also includes obsessive compulsive disorder, panic disorder, and agoraphobia. So just launching into some of the results from the report, mood and anxiety disorders are definitely a major public health issue, with about 3/4 of Canadians who used health services for mental illness annually consulting for mood and anxiety disorders. And then every year, about 1 in 10 Canadians uses health services for mood and anxiety disorders, and that's about 3.5 million Canadians receiving health services for mood and anxiety disorders in 2009-10. So this slide shows the annual prevalence and rate ratios comparing females to males across the time period of the report. And so we can see that the health service use has remained fairly stable across the period from 96-97 to 2009-10. And across the period, you can see the orange line is females and the purple line is males at the bottom. It looks a little different on the screen, actually projected, but on my paper copy. So the second line from the top is females, the bottom line is males, and females are consistently higher than males across the period. And then looking at the rates by age groups, in the younger age groups from 1 to 19, we can see that there were possibly very small increases, less than 1% in the young age groups from between ages 5 to 14. That's where the largest increases overall were seen, but as I mentioned, they were less than 1%. So among the age groups from 20 and over, we can see the highest prevalence was observed among ages 30 to 54, followed by those 55 plus. So this presents, in terms of age-specific rates across 2009-10, and we can see that adolescent and adult females were more likely to use health services for mood and anxiety disorders compared to males of the same age. And this presents across the jurisdictions, and we can see, again, that women are consistently more likely to use health services for mood and anxiety disorders across the jurisdictions as well. Here we see some of the comorbid conditions, including asthma is the top line, COPD is the second line, ischemic heart disease, the third line from the top, followed by hypertension, and diabetes is the bottom line. But so we can see that in all conditions, chronic conditions are more prevalent among people using health services for mood and anxiety disorders. So just a few strengths of the CCDSS data. It is longitudinal data, as mentioned, starting from 96-97 forward. We're continuing to collect it. It provides virtually complete coverage of the Canadian population. It complements clinical medical records and community health surveys and provides potential for data linkage studies. The CCDSS platform remains stable over time, and it provides an opportunity to look at comorbid conditions among different chronic diseases. So just in summary, about 1 in 10 Canadians used health services for mood and anxiety disorders annually. Canadian adults, particularly those between the ages of 30 and 54, are more likely than children and adolescents to use health services for a mood and anxiety disorder. The largest relative increase was among children and youth ages 5 to 14, but in absolute terms, the increases were less than 1%. Across all jurisdictions, women were 1.7 to 2 times more likely than men to use health services for mood and anxiety disorders. And chronic conditions, particularly asthma and COPD, were more prevalent among those using health services for mood and anxiety disorders. So a few expected impacts of this report. It's tracking the use of health services for mood and anxiety disorders over time will help us to evaluate the impact of public health interventions and monitor subpopulations at greatest risk, including children and youth and middle-aged females. It will be useful for increasing the collective understanding of mood and anxiety disorders and related healthcare use in the Canadian population, and it will help stakeholders in their efforts to reduce the burden of mood and anxiety disorders in Canada. So some of our future plans for mental illness surveillance using CCDSS, the collection of data on mental illness and mood and anxiety disorders is ongoing. We're continuing to explore the feasibility of developing case definitions for other mental disorders, currently focusing on schizophrenia and delusional disorders. We are conducting a study on the chronicity of mental disorders, tracked through the CCDSS in terms of defining what an episode is and working with that. We will continue to explore other comorbid diseases and conditions as they're added into the CCDSS, so including stroke and other neurological conditions and others as they are added. And we're working towards developing indicators of the mortality impacts. So this graphic just highlights some of our dissemination methods. So consistent with the Open Government Initiative, the data in this report are available through both the data cubes and open data. Things are circulated through email and chronic disease listserv updates. We disseminate via peer review papers, conference presentations on our websites, healthycanadians.ca and the PHAC website, through social media, through the Chronic Disease Data Lab, which is available through the InfoBase, which is where the data cubes live as well as through webinars such as this. So this long list is probably missing a few names, but it's the very many people who played a part in the expansion of the CCDSS to include mental illness and the production of the report. So it's definitely a big team effort. And then there are external partners as well who played their part in terms of our mental illness working group, the CCDSS Science Committee, CCDSS Technical Working Group, and our Mental Health and Mental Illness Surveillance Advisory Committee. And so that concludes the overview of the report. There's my contact information, and thank you very much for the chance to present, and looking forward to answering your questions.
Okay, thank you. This is Siobhan presenting here, and I'm honored to be able to present on behalf of my esteemed colleagues on a recently published study entitled Underdiagnosis of Mood Disorders in Canada. The underdiagnosis of mood disorders occurs worldwide, and using data from the 2012 Canadian Community Health Survey, the Mental Health Survey, we had the opportunity to characterize and compare Canadians with symptoms compatible with mood disorder, with and without diagnosis, as well as to describe their health status, health service use, and perceived need for care. So this paper is hot off the press as well, and it was recently published in the journal Epidemiology and Psychiatric Sciences, and the list of authors are there, my esteemed colleagues, Louise Pelletier, myself, Jennifer Dykson, Louise McRae, and Scott Patton. Due to copyright issues, access is limited, but the article is likely available through most organizational journal agreements. So just some background just to frame the study's purpose. So mood disorders, including depressive and bipolar disorders, are one of the most common types of mental disorders in Canada and worldwide. These disorders can have a major impact on people's lives. According to the 2010 Global Burden of Disease Study, depressive disorders, which are more common mood disorders, alone were the second leading cause of years lived with disability in North America and globally. While these disorders are very prevalent, their under-recognition and under-diagnosis is an ongoing public health concern, given the associated risks of increasing severity and chronicity when they're not recognized and not treated appropriately. The aim of our study, again, was to examine the characteristics and the health status and health service use, as well as perceived need for care among Canadians that were 15 years and older that had symptoms consistent with a mood disorder, and we looked at these individuals by diagnosis status, whether they had a professionally diagnosis or whether they didn't. So the data source, as I've mentioned, is themed, one of the CCHS special theme questionnaires in 2012. It covers the Canadian population age 15 plus living in community dwellings in the 10 provinces. Excluded from the target population were persons living in the 3 territories, those living on reserves and other Aboriginal settlements, full-time members of the Canadian Forces, and institutional populations such as seniors living in long-term care, as well as those in correctional facilities, which represent about 3% of the target population. So in terms of the key measures for this study is, one, we use the symptom-based. Respondents were considered to have symptoms consistent with a mood disorder if they met the World Health Organization's Composite International Diagnostic Interview criteria for one of the following disorders: major depressive disorder, bipolar 1 or 2, or hypomania in the previous 12 months to the survey. This was, the WHO CDI was modified for the CCHS specifically to be administered in that fashion in terms of a national-based survey. Our second measure was looking at self-reported professionally diagnosed mood disorders, where respondents were asked, had they been professionally diagnosed with this disorder, by answering yes to the following question. Remember, we're interested in conditions diagnosed by a health professional and are expected to last or have already lasted 6 months or more. Do you have a mood disorder such as depression, bipolar disorder, mania, or dyspnea? In terms of the study sample, so again, the CCHS Mental Health Survey surveyed Canadians 15 years and older in the 10 provinces using a multi-stage stratified clustered sampling design. The overall survey response rate was close to 70%. A total of 23,709 respondents comprised the share file, which is the file that is distributed to Statistics Canada's share partners, of which the agency is one. And for this analysis, we had to exclude 205 respondents because they had missing responses to either one of the 2 measures I just mentioned. So for a final study sample, we had 23,504 respondents. So some key findings now. This pie chart represents the entire CCHS sample, and in red and blue are those that had a mood disorder symptoms in the past 12 months, which represents about 5.4%, of which is also, or 1.5 million Canadians, of which half of these individuals reported having received a professional diagnosis. So in red here, and these color codes carry on through the remainder of the presentation. So in red we have those that have symptoms but were not diagnosed, and in blue we have those with symptoms but they were diagnosed. So now we're just looking at some of the socio-demographic characteristics of those with symptoms by diagnosis status, and we found that the two groups were quite different. Those that were undiagnosed were more likely to be younger, to be single, less educated, have no physical comorbidities, and to actually be in some of the higher household income quintiles. Now, looking at some of our health status measures, which cover both physical and mental health, such as perceived health, perceived mental health, satisfaction with life, psychological distress, as well as level of disability. And again, we have those with symptoms not diagnosed in red, symptoms but diagnosed in blue, and then we also have all of those that without mood disorder symptoms in green. So from this you can see those that were undiagnosed were less severely affected than those diagnosed, but they were much worse compared to those without symptoms altogether. Now we're looking at more the health service use and perceived need for care. And in terms of health professional consults in the past 12 months, we also looked at mental health professional consults in the past 12 months and also perceived need for mental health care. We found the majority of undiagnosed individuals did not consult a health professional, but yet 1/3 reported that their needs were only partially met or not met at all, which was similar to those that were diagnosed. So there's, again, confirmation of that well-known care gap in mental illness management. So in conclusion, mood disorders are common and can profoundly affect the life of those that are affected, but their diagnosis remains suboptimal and healthcare use falls short of their needs. Therefore, improvements in mental health literacy, health-seeking behaviors, and diagnosis are needed. Considering the heterogeneity of those affected, like in terms of their symptoms, severities, and also the impacts and prognosis, we really need to tailor the type of intervention, and these interventions need to range from watchful waiting, self-management strategies such as exercise, meditation, things that are known, alternative therapies known to make a difference for those that are milder cases, to more the traditional psychological and pharmaceutical treatments for the more severe cases. So while our study has many, many strengths, including the large population-based sample and including the administration of the survey by trained personnel using a recognized validated instrument such as the World Health Organization Composite International Diagnostic Interview, we do have limitations of which that the results need to be interpreted in light of. We have limited coverage of the CCHS, many subpopulations known to be at risk of mental illness, for instance, Aboriginal populations living on reserves or Crown lands, the homeless, institutionalized individuals, long-term care and correctional facilities, also full-time members of the Canadian Forces. They're all known to have elevated prevalence of these disorders. So in essence, our results are conservative as a result of that. Results are also subject to recall, social desirability, and non-responder bias. Often people with these types of disorders may not participate in such surveys, these kind of surveys. So really we need to consider future studies to do triangulations of using different data sources to best try and capture those that perhaps are not likely to participate or may not disclose information that they're not comfortable with. Also, the symptoms were not assessed by a mental health professional, which is considered the gold standard. Symptom severity was not measured in the survey. And also there was different reference periods for the symptoms and the professional diagnoses. And lastly, we can't draw any causal inferences between these disorders and the health-related outcomes because it is due to the cross-sectional nature of the survey. So that just wraps up, give you a snapshot of the findings from the study. And again, I'm happy to answer any questions that you may have, but I believe we're moving on to the next presenter. But feel free to contact me if you have any questions about the study. I'd be happy to address them after the presentation too.
Wow, that was a lot of data. I'm not a data geek, unlike my esteemed colleagues, so I'll be taking it down a little level, more conceptual, talking to you about mental health versus mental illness. So you've heard a lot of information about mental illness, a lot of data, but what I want to talk to you today about is mental health. So in Canada and throughout the world, mental health is increasingly understood as an individual and a national asset that should be framed in positive and constructive terms. People hear mental health, they think mental illness, stigma, and other negative connotations. And while the concepts are related, they are distinct. Everyone has mental health. We all have a level of mental health, just as we all have, we're all in a state of physical or like physical health as well. We have good mental health when things are going well, when we're coping well, enjoying life, or we have poor mental health, perhaps we've lost a loved one, trouble coping with our children, ended a relationship and are just not doing well. So I really want to stress that mental health is not mental illness. At the agency, we define mental health as in terms of positive mental health, being the capacity to feel, think, and act in ways that enhance the ability to enjoy life and deal with challenges. It's also a crucial part of overall health for everyone and an essential resource for living, and it brings benefits to us as individuals, those of us living with or without a mental illness, across all ages and to society. And I guess we've seen through the previous presentations that quite clearly mental illness is a biological condition. It causes alterations in thinking and mood and behavior, and it's associated with distress and impaired functioning. We believe quite strongly that promoting mental health, we take a public health approach where we are trying to prevent a disease, and then we step to mitigate the effects of it. So promoting mental health decreases the risks of developing a mental illness, and it can also help those living with or experiencing mental illness to cope with their symptoms and ultimately recover. Okay, it's important to note that mental health promotion, as I've said, can help everybody, people living with or without a mental illness, to improve their mental health. So we could augment the positive feelings that people are experiencing, or we can help diminish some of the symptoms of mental illness. Positive mental health is a state of feeling good and functioning well. It includes concepts such as emotional well-being or happiness, psychological well-being, meaning that we are able to engage in meaningful activities, social well-being, we're feeling supported in the community. Mental health promotion aims to promote this mental health, strengthening competence and resilience, and by creating supportive living conditions and environments through addressing social determinants of health. Social determinants of health, as most of us know, are the conditions in which people are born, live, and grow. A couple examples of a social determinant of health include education, early life experience. So mental health promotion addresses protective and risk factors that are based on the social determinants of health at both community, family, and individual levels. There in the bright red are some risk factors that are identified, and these, when experienced, are associated with negative mental health outcomes, particular to the agency's interest, child abuse and neglect, also family violence and conflict. In the green are protective factors. They're associated with positive mental health outcomes, with mitigating or preventing altogether negative outcomes. And again, specific to our agency, positive school and work environments is a protective factor. Supportive family and social relationships, as well as positive parenting, are things that we are working to support. Okay. I'll begin by saying our standard line, that we do recognize that provincial and territorial governments do have primary jurisdiction for the planning and delivery of mental health services in Canada. However, the federal government does deliver direct services to several populations, to which Louise had alluded earlier, and I'll just add as well refugees and newcomers. So the agency the Public Health Agency of Canada is the federal lead in mental health. But we, along with other government stakeholders across Canada, help to foster environments that support mental health, prevent mental illness. As well, we provide, we're a funder in that we provide block funding through the Canada Health Transfer. Other ways we try to support promotion of mental health is through leadership, coordination, and strategic policy development. We heard some stuff today about the surveillance, monitoring, and evaluation. We also strive to share knowledge that we've developed, community-based programming and community building, looking into disease and injury prevention, as well as intervention research. And I guess intervention research means going out, trying different programs to identify where we can most successfully have an impact on improving mental health. So the next couple slides, I'm just going to give you a couple examples of the agency's activities and programs where we try to promote mental health, prevent mental illness. Okay, surveillance and reporting on mental illness, self-injury and suicide, child maltreatment, and positive mental health indicators are things that the agency does. Looking at core public health activities designed to guide and evaluate decisions about policies, programs, services, education, and research relating to mental health and mental illness. Something that's sort of new-ish here with the agency. As you've heard, a lot of the reporting is about mental illness. But as I said, we struggle with the fact that mental health can be good, and how could we capture that? So in the last couple of years, work with one of our teams has been dedicated to looking at measuring positive mental health in Canada. So you can see there are different categories for what they look at. They've broken it down across sector, I guess, individual, family, community, society. And in general, Canadians seem to be feeling okay. If you want to know exactly how okay is operationalized, I encourage you to go to our website. And the newest infographic to join the agency is looking at social support and positive mental health, and looking at how relationships and how we relate to others, family, communities, really does affect how we feel and how we function, and so there are data looking at that. So this is pretty exciting, a step forward to sort of looking at mental health as an asset and as a good thing. So looking at knowledge development and exchange. Because Life Goes On is one of the most requested publications, and it actually does still exist in hard copy, although limited. And we've had over 25 years. We've recently this year updated to the third edition, and it's been released, I think it's been officially released last week. So Because Life Goes On looks at helping children and youth live with separation and divorce. So what it does is it tries to give tips and tools from a mental health promotion approach to look at what the kids and youth need as they are going through separation and divorce at every stage of their life from birth to adolescence. It also builds on and supports parents' desire to take good care of their children and their capacity to do so. So it's an exciting booklet. It's quite large. It touches on a broad range of public health issues, such as mental and physical health, parenting practices and coping skills, as well as children's resilience, family violence, anger, abuse, and isolation. And it includes all different kinds of families. So whoever picks it up is going to be able to see themselves in there. Another example that I don't have on the slide, but that works with families, is the Nobody's Perfect program for parents. I like that one because it reminds me that I don't have to be a perfect parent. It as well is available on the website, but again, it's another tool to help equip families to intervene. The agency is really keen on their interventions being early on. Large focus of our work is on infants, children, and youth. So we see things that are really there to support parents, to support caregivers in getting the first 5 years as right as possible. So I've explained a little bit about what intervention research is. The innovation strategy was launched in 2009, and it's a pretty unique program. with its goal ultimately being to identify what works in public health. The program was established to break new ground in population health by supporting innovative, equitable, and evidence-based public health interventions. And then once identifying the best ones, sharing those results of the projects so that they could be used where needed across Canada, adapted, scaled up, so looking at increasing scope and reach. For example, the innovation strategy funds school-based interventions, and they focus on increasing the social and emotional competence of children and youth in a way that enhances existing supports and builds on community strengths. So having the curriculum built in a way to support them. Other interventions address, as I just mentioned, parenting competencies, family cohesion by focusing on parents and caregivers to develop skills and knowledge to support positive mental health from birth to age 6. Obviously, this would be across the life course, but specifically we're investing in resources to assist children as young as possible, even prenatally with parenting programs. These programs are delivered in-home, in some homes and in the community, and they're, again, promoting mental health and with ultimately the goal of preventing or mitigating mental illness. I should say that all of our work and activities in mental health and mental illness are consistent with the Mental Health Commission of Canada's National Mental Health Strategy that was released in 2012, which the Government of Canada, our neighbours over in Health Canada, are the funding holders for that. So some of the work that we do that supports this strategy is mental health research, again, community-based health promotion for families, as well as interventions for First Nations and Inuit mental health and addiction programs and services. As well, the Public Health Agency invests annually in community-based health programs. One of those is the Community Action Program for Children, again, strengthening parenting skills. It looks at specifically at-risk children and their families, and again, adopts a mental health promotion approach. PHAC is also leading consultations on the development of the federal framework for suicide prevention. And this, when released, the framework is intended to improve federal activities in the area as well as enhancing public understanding of suicide and suicide prevention. I think I've hit my main things here. I don't have a contact sheet. I should have thought of that. So you can certainly go onto the Healthy Canadians website to look into any of these things that I've mentioned. Or you could also, and I know you have Louise and Siobhan's contact information, so if you just put Tracy.Reynolds in front of that very long @PHAC that goes on for a bit, I am sure to get it. Otherwise, feel free to send something to Siobhan or Louise. They're just one floor up, and they're kind folks, so I'm sure I'll get your questions. Okay, so I guess now we turn to Bill.
Great, thanks. I'm here. Thanks very much, Tracy, and all our presenters. That was really great. Definitely learned a lot and have a lot to digest, I think, along with all of our participants. And there's been questions coming in all throughout that we'll now start answering. I think I'm going to hand it over to Neil Rancourt, your colleague Neil Rancourt, who's in the room with you at this point, to moderate those questions. So, Neil, if you're ready, I will hand it over to you.
Okay, I think we're going to start with Louise's presentation on the CCDSS report. And Louise, do you want to start with the list? Okay. Okay, we have a first question from JDV asking a question on the healthcare use stats, those slides. Is this a function of the capacity of the healthcare system, or actually demonstrating the need?
That's a very good question. With the data that we're using, it really is the use of the healthcare services. So it's not we're not able to capture the need beyond that. So it really is. You're right. It's capturing. It's capturing more the capacity, what's being handled at this point in time. So through other data sources such as surveys, Siobhan mentioned some variables related to perceived need for care and that type of thing. We're able to piece together information from other data sources to try to complete the picture.
Okay, thanks, Louise. The next question from the same participant is, what is the reason that women are using health services more? And he also goes on to have a note on, I think this is just a note saying whether it's worthwhile to examine the flexibility of employment related to seeking and maintaining health care for mood and anxiety disorders. But it's mostly just to ask what the difference is between the sexes.
Right.
And why.
Within the actual report, we do expand on this, delving into the literature a bit to try to better understand why the rates are higher among women than men. What we report on, it's really a combination of several factors. There's no clear answer, but the factors that we identified include bias in the detection of health conditions in adult females, since they are accessing health services more frequently than men. Depression can be more easily recognized in women when considering differences in the symptoms associated with depression. Females tend to express the more classical symptoms, while males are more likely to be irritable, angry, or discouraged when depressed. So they present quite differently. Moreover, hormonal fluctuations related to aspects of reproductive function may predispose females post-puberty of childbearing age to depression more than the males of the same age. And there's also a variety of cultural and social differences, such as work and family responsibilities, that can play a role as females report experiencing greater work-family conflict than males. So it's really, there's a number of things at play there.
Okay, thanks, Louise. We're gonna take a couple of more questions, and then we'll move on to Siobhan and Louise P. Question 3: does the study look at the number of people who sought out OHIP paid health care on a long wait list, and does it look at those who sought private providers?
So what's included in the Canadian Chronic Disease Surveillance System is services that are used from either physician billing or hospitalization. So unfortunately, it's not able to capture people on wait lists, and it's within the healthcare system, so we're not able to capture private practitioners. There are situations in certain provinces and territories where there's shadow billing, where a physician will submit a bill to their province and territory for tracking purposes, but coverage is not complete. So there are limitations to the data. However, it's as I mentioned previously, a part of the puzzle of piecing together the bigger picture.
Okay, thanks, Louise. Hopefully that clarified the question. I have another question. It's 2 parts. First part of it is, what are the future plans for the CCDSS in terms of national surveillance for mental illness? And then the next question after that is, why were psychological services not included?
Okay. So some of the future plans include the ongoing surveillance of these conditions, so mental illness overall, mood and anxiety disorders, and we are also looking at expanding to include schizophrenia and delusional disorders, as well as other indicators around chronicity in terms of the length of episodes and frequency of episodes, looking at other comorbid conditions as they're added into the system. So certain neurological conditions are being added at this point, and stroke. And we're also developing indicators of mortality. Sorry, what was the second part of that question?
Oh, the second part was why were psychological?
Again, that
Psychological services.
yeah, it goes back to those being private and outside of the healthcare system. Where at this point there's not a national data source for psychological services. We're looking into possibilities there. Unfortunately, there's not a standardized data source at this point, but we're aware of the gap and trying to find ways to fill it.
Okay, thanks, Louise. I think there are a few more questions, but I think we're going to go to the next paper and see if we can come back to any of the other questions regarding the CCDSS report. So one of the first questions for Siobhan was, again, from JDV. I would be interested, I think this was just a comment actually. I would be interested to see studies looking at mood disorders and concussion-acquired brain trauma. So in terms of if there's any work going on there or anticipated. And then from Ken Say, was gender considered in compiling the diagnosed and undiagnosed categories?
Yes. Well, sex, females, males, was explored among the many sociodemographic characteristics. I didn't present it because there wasn't significant difference in terms of sex between those that had a diagnosis versus those that didn't. But just to give you the numbers, those while there were a higher proportion of females in the diagnosed group, 66%, comparatively speaking to the undiagnosed group, there was 56% were female. However, this wasn't statistically significant.
Okay, thanks, Siobhan. There was another question from Sue LaRock asking, is there possibly a correlation between severity of symptoms and the reason for underdiagnosis versus the severity of symptoms deeming a need for seeking attention and therefore getting a diagnosis?
Yes, and while I had mentioned one of the limitations of the study was that we weren't able to assess severity, the proxy were a lot of those health status measures that I reported on, and while, as I demonstrated, the health outcomes suggest that the impacts were less in the undiagnosed group, we cannot lose sight of the fact that this undiagnosed group did meet the diagnostic criteria to the DSM-4, so they clearly have mood disorders, and that their health outcomes were actually worse than those without mood disorder symptoms. So we can't exclude the problems with mental health literacy and health-seeking behaviors in this particular group. But yes, our results do show that perhaps the health impacts might be less.
Okay, thanks, Siobhan. There's one more question, and the question is, what proportion of those who reported being diagnosed did not meet the symptoms in the past 12 months?
Okay, yeah, we actually did look at that. While it was not included in our study, we found that those with the diagnoses that did not have any mood disorder symptoms was 4.3% of the sample. So that goes, the interpretation of that is that, yes, at some point they received a professional diagnosis, but at the time of which the survey was done, they did not have symptoms in the previous 12 months. So we assume that these individuals were in remission or they had subclinical symptoms and therefore, yeah, they didn't present with symptoms. But this was not a focus of our study.
Okay, thank you. And before we go on to a question that I think was meant for Tracy, we have one more that you might be able to answer, and I think it's regarding the CCDSS study, or actually the data from CCDSS. And the question is from Sharon DaCosta. Is it possible to extract data specific to perinatal mental health disorders?
At this point, no. Our case definitions include the broad mental illness and the specific mood and anxiety disorders. what we get from the provinces and territories is aggregate data, and we are also limited to what's available at a common level across all provinces and territories. So there's a limitation in how finely we can define certain conditions. So at this point, unfortunately, the answer is no. There is work within our division on postpartum depression, and so at this point there is a fact sheet on the website regarding postpartum depression for more information, but specifically from CCDSS, no.
And I think actually that particular fact sheet sources the maternity experiences survey. Okay, and so we have another question that perhaps Tracy might be able to answer. So the question was posed, was it possible to identify individuals diagnosed with a mood disorder yet reporting positive mental health or no symptoms as a result of positive supports and or treatment?
Okay, that's a really good question, near and dear to my heart. We don't have data necessarily, but we have for years understood mental health to be, and we're sort of working away from it now as surveys sort of question some of the findings, but it is certainly possible for someone who has a mood or anxiety disorder to have positive mental health. I'll talk about myself. I've had OCD and panic disorder diagnosis for over 20 years. I'm very lucky. My OCD is very treatment positive and well done. And so despite the fact that at every point of my life, pretty much since 17, I've had this, I have a very good level of positive mental health. I have strong work relations, good family relations. I feel pretty good, and I will leave it up to my colleagues to determine how well I function. I think I function fairly well, but, you know, and those of you who are out there, don't write in. So it absolutely is possible. Where the data get tricky and why we're moving a bit away from the mental health, high mental health, low mental health versus high mental illness, low mental illness, is that the data have shown that while we would like to think that everybody can benefit from mental health promotion to improve their positive mental health, we do have to acknowledge that there is a population of people living with such severe mental illness that for most it is possible to have anxiety or mood disorders and have good mental health, but there is a pocket of people whose mental illness is so severe that I think it would really be misrepresentative of me to say that those people can benefit as well. So I would say that most can, but certainly the more serious mental illness, I think the more challenging it would be to have positive mental health, although there's no reason why we can't try to introduce and work with that population. So pretty much anywhere where your mental health is, we're striving to up it a little bit.
Thanks, Tracy. And we do have another question, a little more general, so maybe you can all answer if you'd like, regarding dissemination. JDV is wondering whether the dissemination of these reports and studies is done through primary practitioners or any major public health professional networks.
Okay, well, I can speak a little bit towards just the ones related to ours. We do have information on, like I identified, Because Life Goes On. It's online. It's also in restricted print copies. A real big partner with this has been Justice Canada, and I know that the Canadian Associations of Lawyers require or have requested many of these that they hand out as part of their practices. People from all over the country can download it or have it mailed to them. Conferences, these things are shared. Mental health days are shared. And certainly, I think they can be accessed by anyone. Our stuff. I'm not sure about
how the data stuff works.
Yeah, and I just to add, I guess from the surveillance perspective, we have distributed things through our listserv and through social media, so they're publicly available. We also disseminate through CPHA and other partners such as the Mental Health Collaborative, MHCC, I'm losing Mental Health Commission of Canada. I'm acronym overload, I guess. And the data collaborative through the Mental Health Commission as well. So it's not an exhaustive list, but hopefully we're reaching the people who need the information. But suggestions, if we're missing anyone, if there are suggestions of areas we should be targeting as well, that would be greatly appreciated too.
It's Tracy. I saw a question about the Because Life Goes On. We're just checking to find out when the official release is. I have seen it in hard copy. I know it exists, and I know that we had to go, our comms process is a bit arduous to get things finally up there. And I was hoping to know now when it was, but it will certainly be up shortly. As I said, it's been completely signed off. It's ready to go, so it's just a matter of trying to get all the technical hoops blocked. So I would say, recognizing the communications and how everyone has to sign off, that mid-September, I've just been told, mid-September is when it will be officially released. It's tremendous. A lot of work has gone into this. It's gone from a small publication to over 100 pages. So we're really proud of that. So if you want to come back to Healthy Canadians in mid-September to find that. And again, if you have any specific questions about the publication or anything, feel free to tracy.reynolds at that long government address, and I'd be more than happy to answer your questions or get you in contact with my colleague who wrote the document.
Thanks, Tracy. We had one comment and sort of partial question that maybe Siobhan and one of the Louises can answer. It's a remark by Rolf Puchinger. I hope I got that right. And he mentions the difference between CCDSS and CCHS prevalence estimates was interesting, and possibly due to different age groups in the denominator as well. It would be nice to link the two data sources for validation.
That's a great question. We actually have a paper that we published in epidemiology and psychiatric sciences that does that comparison. While they weren't linked, it's much more of a kind of ecological study looking at those with mood and anxiety disorders using self-report data from the CCHS over a 5-year time period, as well as the CCDSS over the same time period. There were differences in the denominator. We ensured that the age groupings were the same, so that isn't a source of the difference. But what we did notice that over that 5-year interval, there was a convergence in the prevalence estimates for mood and anxiety disorders between the two data sources. The admin data estimates were always higher and more stable, but what we noticed with the self-reported estimates that there was a convergence over that 5-year interval, and that difference was different by age group. With those that were younger, the narrowing of the two estimates was increasing over time, which led us to think, hypothesize, speculate, we can't confirm, but from those results that perhaps with health literacy programs and initiatives that perhaps targeted at younger people, we might be improving the self-disclosure of these disorders. Louise, do you want to mention, Louise Peltier wants to jump in here to mention something else. She's hovering over me and I don't know what she's saying.
It looks like jumping.
Yes, hi everyone. So what I wanted to mention to Ralph is obviously Siobhan is mentioning a study looking, comparing CCHS data versus CCDSS. However, obviously the study she presented today is based on a different methodology, is the CCHS Mental Illness Special Survey, which did, identify case of mood disorder, anxiety, etc., based on symptoms, not necessarily by diagnosis.
Right.
So it's another piece of the puzzle.
Yes.
But yes, I mean, I think what we can say is, yes, our estimate seems a bit slightly lower than what we were expecting for mood disorder. And maybe it may be because of, non-respondent bias, because in any survey, obviously, you have people who agree to participate and not participate, while the CCDSS covered the whole population using health services. So there are different, obviously, type of, source of data with strengths and weaknesses for each of them. But as Siobhan was mentioning, it's really the triangulation of all those data which gave us the best picture of all.
And to follow that up, there is work being done by ISIS currently that PHAC is contracted that maybe Louise could speak to.
Yes, we had contracted with ISIS, Institute for Clinical and Evaluative Sciences in Ontario, not the other ISIS, to do a triangulation between the data sources. So this was looking at CCDSS in Ontario, CCHS, and their electronic medical records. I can't speak to results at this point in time, but just to let you know that triangulation has been done, and so we will be able to look at where people are being captured within those three databases and what's included in one and what's missing in another. So that will be a wealth of information for us.
Okay, I think actually we had a couple of comments that I think Tracy would like to address.
Sure. Okay, I have two written down. I just see something on the screen. Where do I find the Innovation Strategy 2009? I will have to find that for you. It was a $27 million program over 5 years. The first phase just wrapped up, so that's probably why you found the evaluation. And it's very timely today. They actually had a presentation earlier today. So if you want to use my name, send it to me, your question, and the IS colleagues are just desks away. I know that they presented today, and we'll probably have a lot of good information. The innovation strategy is one of our best stories in terms of really identifying mental health promotion techniques that really work and are being found to improve the capacity of kids in school and in families. So I think it's a really good thing to ask about. So just connect with me, and I will be happy to get at least a copy of today's presentation, which I heard was excellent. So hook up with me for that, please. Also, I saw that there was a reference, and I'm not sure, I think it was at JDV, on diet. Okay, so looking at diet and nutrition. You can look at this in diet, and if I'm too loud, just flag me because it always happens. There are some documents that PHAC has produced that look at nutrition and mental health. I could find them for you, and it's not within my group, but I do know that there was the nutrition group did prepare something on nutrition and mental health. Of course, what we eat affects how we feel. So, eating can cause, a variety of the chronic diseases that they've spoken about today, and that there is a very strong dual directionality between mental health and chronic disease. We didn't really get into that today, but if you have a chronic disease, persistent illness, that of course is going to take a toll on your mental health. And as well, if you are experiencing a moderate mental illness, you're not coping well, you're not functioning well, so you're likely not eating well. And so that sort of bumps you back into maybe you're not physically well. So nutrition is important, what we eat is important, but also something that's been in the news a lot, the Standing Committee of the Status of Women released a report on eating disorders among girls and women. And so there is an example of eating disorders and diet. So diet comes in several ways, and there are strong ways that it can affect our mental health. I'm not sure how much actual work we've done other than the nutrition book, Nutrition and Mental Health, which would be on our, hopefully, Healthy Canadians website. If it's not there, we're transitioning websites. You could try it on the PHAC website as well. If you're really keen to get the publication, I know people who know people. I can get my hands on it. So again, just the Tracy.Reynolds at the long thing will bring that to you. Someone referenced mental health literacy, and has that been something that we have done? We've tried. We have so many competing desires for things to work on, but certainly mental health literacy is an important issue, and we have not yet worked on that, but we will pitch it again. I think it's really important. I always dreamed of having, the Canada Food Guide. I always thought, Canada's mental health guide would have been a neat thing to do, but anyone has $50,000, you can let me know. So I think, have we identified any other questions of my colleagues? Yes, we do not have resources on mental health literacy. You'd have to go online for that. But as I said, I think it's a very important area. We just haven't got the budget to do that. You may also look at the Mental Health Commission of Canada's website. They've got so many great programs going on. If you just go to their website and key in mental health literacy, there will likely be something there for you. But as I said, if you're unsatisfied with what you find, you can come back to me. So I guess, has everybody asked us everything we're being asked?
I think we've got through most of the questions.
Hi there. Yeah, we've got about 5 minutes left, so if any more questions come in, we probably have a minute or two to answer those. But maybe at this point, as we start to close down the webinar, I just want to thank you so much, Louise McRae, Siobhan O'Donnell, and Tracy Reynolds for presenting today and sharing all this information with us. And it's very kind of you to leave your emails in the slides so people can get in touch with you if they have additional questions or are looking for more information. And also, thanks, Neil Rancourt, as well. You've done a really great job moderating the questions, so thanks for that. And this was a real full webinar of questions with very engaged participants. And want to thank our participants as well for hanging in there for nearly an hour and a half. We really appreciate you joining, and if we can provide any more information or if you have any questions, do let us know. And the last thing, I guess, from me is just that I also wanted to thank the Public Health Agency. We're really enjoying working with you to co-host these webinars and looking forward to many more to come over the next year. So ask our participants to also watch out for upcoming webinars as well. Any final words from our presenters?
Well, just to thank all of the participants again as well for joining us today, and feel free to contact us with additional questions.
It's Tracy. I just want to thank my CCDP colleagues. I'm not a native to this group. I'm an outsider. So I was very happy to come in and talk a little bit about our view of mental health, mental illness. It's something we're trying to get out there. So I really appreciate that some time was given for me to flog the mental health. There's no health without mental health, and that mental health is not mental illness. So thank you very much. I'll give you $5 at the end.
Well, thanks very much, everyone. Wishing all of our participants good mental health, and goodbye, and have a great afternoon.